All right, let's get rolling here. So good morning, everybody. Happy Friday. Welcome to this week's AMSSM Sports Ultrasound case series. We are continuing our sports medicine fellow portion of this series with Dr. Shelby Johnson today. Shelby did a PM&R residency at the Mayo Clinic, where she is currently the sports medicine fellow. And then next year, Shelby is staying in Minnesota. She's heading to Summit Orthopedics up in Minneapolis. So with that, I will pass it over to Shelby.
All right. Brian, can you see my screen?
Yep, looks great.
Perfect. So hi, everyone. Thanks for joining this morning. And thank you to Dr. Cruz, Dr. Hoffman, and Dr. Hall for inviting me to present a case for this awesome series. As Dr. Cruz said, I'm Shelby Johnson. I'm the PM&R Sports Medicine Fellow at the Mayo Clinic in Rochester, Minnesota. And today I'll be going over the ultrasound evaluation of the posterior medial knee in the context of a patient I saw this year. So I have no disclosures, but I do want to give a shout out to a few of my mentors, including Dr. Sellen, who's my current fellowship director, who helped me with this case, and then as well as Dr. Smith, Dr. Jelsing, and Dr. Wisniewski. So the primary objectives of this presentation is to understand the protocol for the ultrasound evaluation of the posterior medial knee, to review the relevant anatomy, identify both normal and abnormal findings, and then to finally compose the diagnostic report. So in regards to the case, this was a 76-year-old avid runner and cyclist who came into our clinic with a 3-week history of acute posterior medial knee pain after slipping while trail running. He was unable to continue running following the injury, and then about 10 days later felt an acute exacerbation of his pain when putting on a shoe. And then he denied any swelling, bruising, or palpable masses. On physical exam, he had an antalgic gait and was favoring his left side. He had significant tenderness throughout his posterior medial knee, especially at the medial aspect of the popliteal fossa, and then extending anteriorly along the pes anserine region. Strength testing was remarkable for pain and give-way weakness with resisted knee flexion and calf raise, but otherwise his knee exam was normal. So it's important to keep in mind that radiographs and other diagnostic modalities are complementary to our ultrasound evaluations, especially when determining if joint or bony conditions are a factor in the patient's symptoms. So here are this patient's radiographs. This is an AP and a lateral of his right knee, and it showed some moderate vascular calcification, but was otherwise unremarkable in regards to fracture or fusion. So at this point, we were thinking of a few things in the differential, including hamstring strain, medial gastrocnemius strain, or a ligamentous injury. So we decided to proceed with a diagnostic ultrasound for further evaluation. So here I've listed the structures that we'll review today as part of the posterior medial knee scan, including the tendons and muscles, ligaments, joints, as well as neurovascular structures. It merges a lot of the posterior and medial scanning protocol structures, but will not be a comprehensive review of all the posterior, all the medial structures. I've also listed some other structures to review as clinically indicated, but will not go over today. And then also important to note, I will not be giving a comprehensive discussion about all the pathology in this region, but will rather focus on the pathologic findings in this particular case. So before every ultrasound evaluation, it's important to think about positioning of the patient, transducer type, as well as the anatomy. So with the patient prone with the knee extended, you can visualize much of the posterior and posterior medial structures. But a sideline position with or without a rolled towel underneath the knee may be helpful, especially in those more medial structures. A high frequency linear probe will be best to visualize those superficial structures, and then trapezoidal view or curvilinear probe may be needed to evaluate the deeper structures as well as give a wider screen of view. And then regardless of region, it's important to think about the anatomy of interest. So this is just a very general review of the main structures of the posterior medial knee. that I won't go into depth now, and instead I'll try to integrate the anatomy as we go through. So as multiple others have discussed before, I like to find a home base for each region for orientation purposes. So this is my home base for the posteromedial knee. Here we're in an anatomic transverse plane just superior to the medial popliteal fossa at about the level of the medial femoral condyle. We expect to see the medial gastrocnemius muscle as the bulk of the lateral aspect of the image. Just medial are the tendons of the semimembranosus, which will be the deeper of the two, and the semitendinosus, which will be the more superficial of the two. And then moving further medially will be the tendon of the gracilis, and then further medially and superficial will be the muscle belly of the sartorius. And so I find it helpful to keep these relationships in mind and remember this as a place to return to if I get lost within the scan. So throughout the presentation, I'll generally depict the transducer position on the knee in the upper right-hand corner, as well as orientations at the bottom right-hand corner of each image or video. So we'll start with that same transverse plane at the posterior medial leg and focus on the medial gastrocnemius, which you can see here. And so in this video, we're short axis to the medial gastroc and going to be scanning proximally from the medial supracondylar region distally to its insertion. So here's the medial gastrocnemius, and then you can see the close relationship of the semimembranosus here and the semitendinosus there. And as I scan distally, we can see that muscle belly with the tendon, and then further in the proximal leg. Flipping to a long axis view as shown on the right, we can see the proximal tendinous origin of the medial gastroc. Oops. And so here we can see the insertion of that medial gastroc. And it can be a difficult origin to visualize just given the overlapping semimembranosus and semitendinosus here, but a combination of heel toeing in, shooting the transducer medially, and then trying to get the best view of the femoral condyle bony contour can help. So a common structure we are asked to evaluate is for the Baker's cyst, which is a fluid collection located between the semimembranosus tendon and the medial gastrocnemius. And so a potential pitfall in evaluating this region is that the anisotropy of the semimembranosus or medial gastroc can actually be mistaken for a Baker's cyst. So in this video, we're again in anatomic transverse plane at the level of the medial femoral condyle. And in this still image, one could mistakenly identify this anechoic region as a Baker's cyst. But once we wag the transducer and use anisotropy to our advantage, we can see that that was actually just the medial gastrocnemius tendon there. So it's really helpful to use our skills and our knowledge of ultrasound principles to evaluate this region. Moving just laterally, we can evaluate the semimembranosus, which plays a large role in the dynamic stability of the knee, and it's an important structure of the posteromedial corner. It's important to understand that it has multiple arms. The two most important are going to be the direct and the anterior or pars reflexa arms, but there are three others labeled in this image. So the direct arm, which is the primary attachment of the tendon to the tibia, is where we'll start this scan. So here, again, we're in short axis over the posterior knee, just proximal to the popliteal crease. So here is the semimembranosus muscle and tendon, and then you can see the gracilis tendon just anteriorly and medially. And then as we scan distally, we can watch this semimembranosus tendon kind of go distally, pass over the joint line, and then insert onto the posterior medial tibia. So we can watch that again as we sweep distally. Kind of goes underneath the gracilis here and then attaches to the tibia. In a long axis view of the direct arm, you can actually visualize the insertion onto this characteristic groove on the tibia, which is a great landmark to use to help visualize this tendinous insertion. In contrast, the anterior arm of the semimembranosus makes an almost 90-degree turn from the main tendon and passes deep to the MCL to insert onto the tibia, just distal to the medial joint line. And so on the left is a short axis view of the oval-shaped appearance of the anterior arm in this groove of the tibia. So there. And then flipping 90 degrees, you can visualize the long axis view of this anterior arm insertion. The semimembranosus bursa, which is not evident in our patient, is also an important structure to keep in mind in this location. It's an inverted U shape or kind of sideways horseshoe shaped bursa. It surrounds the distal semimembranosus tendon and separates the tendon from the medial tibial plateau, the MCL, and the semitendinosus. So superficial to the semimembranosus tendon at the posterior medial knee is the semitendinosus, which is one of the three pes answering tendons. Dr. Onishi reviewed these tendons from more of the medial perspective, so I'll cover them from more of a posterior medial perspective. So again, I'll start in short axis, and I've outlined the semitendinosus here, which is just medial to the medial gastrocnemius muscle below. And as we scan distally, we can demonstrate its relationship to the medial gastroc here, the semimembranosus more medially, and the remaining posterior medial knee structures. And so here it's inserting on kind of the anterior medial tibia. And so that insertion can be visualized in more of an oblique sagittal plane, and it's best done by finding the tendon first in short axis and then flipping on it to make sure that you're on the semitendinosus instead of the gracilis or sartorius, for example. And the pes answering region I know is more of an anterior medial knee structure, but it's essentially the continuation of multiple posterior medial knee structures. So an important area to evaluate in someone with posterior medial knee pain. So for educational purposes, the images I had just shown were of normal anatomy. So these next few videos are what we found in our patients. So here we're in the same orientation as the video from the prior slide. And we're again sweeping anterior medially from the popliteal fossa toward the anterior medial tibia. And so I've highlighted the semitendinosus here that you can follow as I play this image. So as we sweep distally, we can see this semitendinosus muscle starts becoming thick, hypoechoic, and then it kind of ends in this tendon stump at about the level of the posterior medial tibia. As I replay this image, you can again kind of see that ending to the semitendinosus, as well as a good amount of edema and anechoic fluid demonstrating likely hematoma at this area of the tear. Now in long axis to the semitendinosus and the posterior knee, we can approximately see more normal appearing tendon. However, it then becomes thickened, hypoechoic, and has this bird beak type appearance to its end. And so we're just kind of scanning slightly distal as we visualize that long axis of the semitendinosus. So I'll go through the diagnostic report at the end of the presentation, but I wanted to include here just a description of the findings. So complete tear of the distal semitendinosus tendon from its pes answering insertion with retraction to the posterior knee at the level of the posterior medial tibia. In this same patient, we're now in, again, an oblique sagittal plane over the pes answering bursa, and we can see anechoic fluid and edema within that pes answering bursa with increased flow on Doppler. And so that's what we described in our report, a small amount of fluid extending into this bursal region with mild hyperemia. So while we've obviously found the pathology in this patient, it's always important to do a complete evaluation, especially when doing and billing for a complete diagnostic ultrasound. So moving more medially, we can evaluate the distal gracilis. So here we are again in short axis at the popliteal fossa, and you can see the gracilis as this fibrillar tendon just medial to the semitendinosus and lateral to the muscle belly of the sartorius. And this is actually the same video I had just shown of our patient. So you can follow the SEMI-T again, but also pay attention to the gracilis and notice that it does have, its complete intact insertion onto the anterior medial tibia in contrast to the semitendinosus. On the right is a long axis view of the gracilis insertion in a normal individual. And as with the semitendinosus, it's helpful to find the gracilis in short axis and then turn on it to make sure that you're on the right tendon and not another structure in the area. Rounding out the pes answering tendons, you can visualize the distal sartorius muscle, which at the posteromedial knee is largely muscle. It attaches the most proximally of the three pes answering tendons and has more of a broad fan-shaped insertion than the other two. So you can visualize it as we scan distally here, kind of forming into its broad shaped tendon and eventually inserting onto the anteromedial tibia. Then again, flipping on this tendon in long axis, you can visualize its insertion here onto the anteromedial tibia. Moving on to ligaments, the medial collateral ligament is best visualized in a coronal plane at the medial joint line with a crisp view of the femoral condyle and then proximal tibia. The origin can be found just slightly proximal and posterior to the medial epicondyle, and the origin normally appears slightly thickened here. At the level of the joint line, you can distinguish the more fibrillar superficial MCL from the more hyperechoic deep MCL, which is composed of the meniscofemoral and meniscotibial ligaments. And so wagging the transducer and using anisotropy in this region can help identify these two layers. And then in this coronal plane, you can also see the body of the medial meniscus just deep to the MCL. And so this is an important place to look for loose meniscal fragments that may set up kind of in the gutters between the superficial MCL and the deep MCL. To visualize the insertion of the MCL, you have to move the transducer about 4 to 5 centimeters past the joint line, kind of in an anterior-medial direction onto the tibia. And you can see kind of that fibrillar structure of the MCL insertion. Just above the MCL insertion or superficial are the three pes answering tendons. And in this normal example, you can see the semitendinosus most distally, the gracilis, and then the sartorius most proximally. And so from proximal to distal, I remember these as Sargent or SGT. And so wagging the transducer using anisotropy help here can help make these tendons become more conspicuous. And then moving on to the medial meniscus. So ultrasound, as we know, is somewhat limited in comparison to MRI. However, it's a relatively quick scan and can demonstrate degeneration, tears, or parameniscal cysts. And so the meniscus should normally be this hyperechoic triangular appearing structure here. And at the level of the MCL, which is where we are here on the left image, we're going to be visualizing the body of the meniscus. And so using a valgus stress on the knee, you can look for any meniscal extrusion or lack of extrusion, which is termed the dead meniscus sign. And this valgus stress can be difficult to perform. However, it's a little bit easier if you put a rolled towel underneath the knee and then apply a valgus stress while keeping the bony contours of the femur and the tibia in view. Moving the transducer just posteriorly with the patient's knee extended, you can see the posterior horn of the meniscus as seen in this image here. And this is a good location to look for medial meniscus injuries. As an aside, it's also important to recognize that if you're evaluating this region, the semimembranosus tendon can actually be mistaken for a cyst in this area. So again, using the anisotropy to make sure that it's not a cyst and rather just the semimembranosus. Evaluation of the posterior root is not a typical part of the ultrasound evaluation, but in certain individuals, it can be relatively easy to see, especially if you have an effusion. And so how I like to evaluate the medial root is to use the PCL as a guide. So a curvilinear probe can help localize these structures initially, but then a linear probe is really helpful to look for detailed evaluation. So with the patient in a prone position, I start in a sagittal plane at the medial popliteal fossa with the patient prone and the knee extended. I then rotate the probe slightly inferior laterally and then tilt the probe medially and use a good amount of heel toe to find this PCL in long axis. To find the posterior root, you then just move the transducer slightly medial and caudal. And so I'll play this again. laterally. There we go. So PCL and then moving medially, you can see that posterior root there. And I've outlined that just in this still image here, the PCL and then the root below. And then using a long axis view is actually helpful to see that root insertion onto the tibia and look for any tears there. The popliteal neurovascular bundle, including the popliteal artery and vein and the tibial nerve, can be seen in short axis in this transverse view over the posterior knee, as well as long axis, which I hear on the bottom right. At the level of the femoral condyles, the neurovascular bundle will be the deepest structures. And to distinguish between artery and vein, you can just compress the area, as the artery will not collapse, but the vein should. And then you can also look at Doppler in this region as well. If a vein is not compressible, it might be indicative of a popliteal vein thrombosis. And then just to mention briefly, if there's concern for popliteal artery entrapment, you can do dynamic provocative maneuvers with resisted plantar flexion to look for compression of the popliteal artery. And you can also look for anatomic popliteal artery entrapment variants, looking at the relationship of the artery to the medial gastroc. A long axis view here, which I have on the bottom right, is actually helpful to look at which point that artery may become entrapped in that syndrome. And so it's a good way to evaluate for popliteal artery entrapment. However, it's good to keep in mind that it's not our test of choice and just something that we can evaluate briefly when we're doing the scan. In this same anatomic transverse plane over the proximal thigh and popliteal fossa, you can look at the tibial nerve, which can be followed from the sciatic nerve as it divides. As it divides sciatic into the tibial more medially and then the common perineal more laterally. The tibial nerve can also be visualized in long axis, which I have here on the right. And so it's this vesicular linear structure just superficial to the artery. Last but not least, to round out the posterior medial knee scan, we can evaluate the saphenous nerve about the knee, which we might think about if a patient has diffuse leg pain not localizing to a musculotendinous or ligamentous structure. So just to review, the saphenous nerve is a terminal branch of the femoral nerve that itself has two branches. The infrapatellar branch can be difficult to visualize and variable in its anatomy, whereas the sartorial branch is the primary branch and the one of concern during our ultrasound evaluation. The sartorial branch, which I've pointed out here on this video, travels deep to the sartorius and then is most easily picked up as it travels distally between the distal sartorius anteriorly and the gracilis tendon more posteriorly. So here we're again in short axis relative to the nerve. Sartorius is here, nerve I have pointed out here, and then gracilis is further posteriorly. And we can visualize that nerve kind of going in between the tendon of the gracilis and the muscle belly of the sartorius, and then dividing into its subcutaneous branches. So finally, we come to the diagnostic report. So with the report, we typically like to include who the patient is being referred by, a brief history, which in this patient, it was a 76-year-old male with acute posterior medial knee pain after slipping while trail running, and then later having an exacerbation of his pain with putting on a shoe. You can put the laterality of the ultrasound as well as the location, the indication for the ultrasound, and then any comparisons or other diagnostic imaging can be mentioned as well. And then it's important to include what transducer and at what frequency you used it. So it's important when we're discussing the findings that we're describing what is seen rather than interpreting what is seen. And so with this individual, there was a complete tear of the distal semitendinosus tendon from its insertion with retraction to the posterior medial tibia. There's a small amount of surrounding fluid extending into the pes anterior bursa. And then there was direct sonopalpatory tenderness just over this region of the distal semitendinosus tendon. And then the remainder of the scan, which I went through today, was normal. And then the impression is where we can use the ultrasound findings in the context of the clinical presentation to make an interpretation. So this patient had a subacute complete tear of the right distal semitendinosus tendon with retraction to the posteromedial tibia. And there was residual dependent hematoma that was extending to the pes answering bursa. And then lastly, it's nice to also include just a plan for the patient and next steps in management, either with follow-up with the referring provider or further management per the sonologist. So I wanted to end this discussion with just some summary points that this case and protocol touch on. So one, ultrasound is a great way to evaluate the posteromedial knee structures, especially those structures that are extra-articular. Two, there's huge value in using the principles of ultrasound to help guide the evaluation. So with the posteromedial knee, there are several structures that are prone to anisotropy. So keeping that in mind or using it to our advantage is really helpful. Furthermore, sonopalpatory tenderness is a great way to really pinpoint the location of these patients' pain and localize it with imaging. And then lastly, as many people have already touched on previously, a home base is a really helpful way to orient yourself before and during an ultrasound evaluation. The posteromedial knee can be a complex area with many structures crisscrossing, and it's just nice to have a point of reference to get back onto track if you're ever lost. So with that, I will finish my discussion and open it up to questions and comments.
All right, thanks. Thanks, Shelby. That was outstanding, and the images that you showed were really fantastic. I thought you did a great job demonstrating, not only a complete sonographic evaluation, but a very clinically relevant evaluation as well. So really great job. I might just make 2 quick points, and then if anybody else has anything they want to add, please feel free. You did a fantastic job describing the distal semimembranosus tendon. I think it's a much more complex structure than we often realize. I think most folks think of the semimembranosus tendon as just the direct arm, but like you alluded to, we can't forget about this anterior limb or this anterior arm, which is, I think a commonly overlooked site of pathology. So great job there. And then the only other point to make, we harp on this, to residents and medical students and fellows all the time, knowing your landmarks, and in particular with the Baker's cyst and knowing where that cyst comes out of. I can probably think of 4 to 5 unfortunate cases where I've had somebody sent to me for, a quote unquote complex Baker's cyst that previously had not been amenable to aspiration, and we throw ultrasound on there, and there's this heterogeneous, complex, hyperemic, nasty structure that certainly does not come out of the normal interval. So making sure that you see where that cyst comes out of before sticking a needle into it is important. That's all I have. Does anybody else have any comments or questions?
Great job, Shelby. I think she really hit on a lot of pearls, including the using anisotropy to your advantage in this area where you have a lot of crisscrossing tendons. I think it's also a nice way, or a nice case of just showing how you can blend together a couple regions. When we're learning ultrasound, we often focus on, say just the medial knee or just the posterior knee during an exam, but when you actually see real patients, obviously you have to combine some of these scans. And so it's good to just get get some practice transitioning. I know Doug has talked about this in the hip, moving from lateral to anterior. And as you get more experience, everybody will kind of develop their own scans that, may not be exactly textbook. And in this case, clearly the problem was crossing over 2 different regions. So great job.
All right. Well, if no other comments or questions, we will move on. So great job again, Shelby. That was, like I said, that was exceptionally well done. Thanks for doing that. Just a quick housekeeping point. So we are off next week. We will follow back up in 2 weeks on April 16th. Maywish Moinudin will be talking about dorsal wrist extensor tendinosis. And again, that's on April 16th. So, all right, guys. Thanks again, Shelby. Great job.
Thank you.
See you, everybody.